Hi guys, I'm back. Hopefully to do some cardio review. Like I said, I want to go over some algorithms and all things related to cardiology. Focus more on step one stuff, but I think it should be helpful for step two as well. So we'll go over some high yield things in cardiology like murmurs, maneuvers, some of the high yield diseases, most common causes of things, and hopefully kind of make this like unique algorithm that I like to do, which is just ask a question and kind of just like build from there with algorithms. Okay. So starting with let's go over, there are three holosystolic murmurs. Do you remember what the three holosystolic murmurs are? Okay, let's answer that first. Okay, nice. Welcome back, blah. Nice. Okay, so the three holosystolic murmurs. This is so helpful in step one, step two, and step three. If they say like something holosystolic murmur, it's gotta be one of these three. And blah has it. You're thinking of mitral regurg, tricuspid regurg, and VSD. Good. Mitral regurgitation, they would talk about a murmur you hear at the apex. And it radiates to the axilla. Huge buzzwords for this one. Okay. VSD, you hear that right above the tricuspid region, so at the lower sternal border. Okay, is where they'll talk about this. Do you guys remember the most common cause of mitral regurgitation? There's two things that you should be thinking of that cause, oops, let me move that around. Two things that cause mitral regurgitation. Okay. I mean, there's many causes, actually, I should clarify. But two things that you should think of first associated with mitral regurgitation. Okay, awesome. I'm getting some good differentials here. You want to think of, let's see, rheumatic fever, absolutely. Okay, you also want to think of subacute bacterial endocarditis. And you can think of mitral valve prolapse that gets worse. All right, awesome, right? So you can think of papillary rupture, you can think of post-MI related complications as well. Okay, so anything that weakens the chordae tendineae, the papillary muscles, or like in these cases, infections. Okay. Anyone remember the murmur that you hear with a MVP? What is this murmur? Oops, kind of going off page here, but what is this murmur? Okay, nice. That's going to be a mid-systolic click. Good. So the murmur you would hear is a mid-systolic click. Cool. Do you remember the bug that causes rheumatic fever? What is that bug that causes rheumatic fever? Okay, good. Group A strep. Nice. Group A strep, or they'll say strep pyogenes, same thing, right? So group A strep pyogenes causes rheumatic fever. What is the bug that causes subacute bacterial endocarditis? Okay. For that one, you would be looking at the viridins group. Good. Okay, draw murmur. Oh, draw murmur man. Okay, yeah. To help separate those, I know a lot of people like to use that as well. Oh, nice. Blah. Okay. Growing from there, let's talk about the diastolic murmurs. What are my diastolic murmurs? Okay, good. So those would be the aortic regurgitation or pulmonic regurgitation, and mitral stenosis and tricuspid stenosis. Good. What do you want to think of as a cause for mitral stenosis? What causes, most common cause of mitral stenosis? Good, right? You also want to think of rheumatic heart disease. So, when you think of rheumatic fever, they'll typically in questions they'll talk about like, is a child who had like symptoms of like a non-specific flu-like symptoms like an infection, and they had a mitral regurgitation or murmur maybe as a child. They might also mention that this child lived abroad, then he immigrated to the US, now they're older, 20s, maybe 30s, and they come back and they have rheumatic heart disease, which is a mitral stenosis. So the first time as a kid is usually a mitral regurg, and then later on in life, when it comes back, it's a mitral stenosis. So both can be with rheumatic fevers or rheumatic heart disease. Nice. All right, let's talk about some kind of conditions that describe these murmurs. So you might see something called S1 and S2 heart sounds. S1 represents, again, first of all, S1, S2 are normal heart sounds. These are not murmurs, they're not pathological, these are normal heart sounds. S1 is usually, you hear it when the mitral and tricuspid valves close. When you close the mitral valve and tricuspid valves. When these valves close, it hears like a sound, which is S1. When would the mitral and tricuspid valves close? They close when you've finished filling the ventricles, okay? So S1 signifies the end of filling or end of diastole, right? They finished filling, we close the cap, mitral and tricuspid valves close. S2, also a normal heart sound, part of physiology, is when the aortic valve and the pulmonic valves close. So when the valves close, the door closes, you hear an S2, okay? So that usually signifies the end of emptying or systole, right? When the ventricles have ejected the blood into the aorta or the pulmonic trunk respectively, right, the doors will close. So that signals the end of emptying. Okay, so to be very, very clear, these heart sounds you hear when the valves close, not when they open. When they close, I think of like a door shutting, you're going to hear a sound. Okay, and that's what S1 and S2 are with these different doors or valves. Now, if the door or the valves are very, very stiff and thick, okay, when you close these very stiff and heavy doors, you would expect that closing sound to be louder, right? So when they say a loud S1 or loud S2, I want you to think it's usually talking about a thick valve, which is more like a stenosed valve. So mitral tricuspid stenosis, aortic pulmonic stenosis would be loud S1 or S2 respectively, right? Conversely, when we think about a regurgitant valve, so I think of like a regurgitant valve is like a floppy valve, right? It's just kind of like swinging around. It's like those like swing open doors, right? They just kind of keep swinging open like a French door. That's what a regurgitant valve is. So when you have like a floppy, flimsy valve or door, right, it doesn't form one clean closed sound. So they kind of just do this for a while until it comes to a rest, okay, when they want to close. So that's going to mute the closing sound murmur. So S1 and S2 would get softer in a regurgitant valve. Okay, that's how I kind of visualize it. So first of all, if they say anything S1, it can only be a mitral or tricuspid issue. If they say S2, it can only be aortic or pulmonic, one or the other. And that really kind of narrows it down for me. If their respective valves or sounds are loud, I think of stenosis. If they're soft, I think of regurgitation first. Okay. Hopefully that makes sense to kind of like organize it. Now, another layer you can add is right-sided murmurs versus left-sided murmurs. Okay, so right-sided murmurs are usually louder on inhale, left-sided murmurs are louder on exhale. Blah. All right, no, Dr. Mariam, we relatively just started. I did a few questions earlier, only about like 4. And now we're just doing this algorithm a little bit. High yield, all things cardiology. Okay. Anyway, so right-sided murmurs, which is tricuspid and pulmonic, would be louder on inhale. Left-sided murmurs, anything with the mitral and aortic, would be loud on exhale. Okay. So let's put it together. If you see a question that says that somebody has a loud S1 on inhale, how would you break that down? Loud S1 on inhale, what would be your answer? Okay, so S1, I know it's mitral or tricuspid only. It's loud. I would think it probably stenosed, right? So either mitral stenosis or tricuspid stenosis. And then on inhale is on the right side. So I narrow it down to tricuspid stenosis. Well done. Oops, that's not showing on the page. Good. Cool. What is the murmur that has a fixed S2 split? Nice, right, Dr. Mariam? So inhalation, inspiration brings more venous return, more preload in the right heart. Okay, so fixed S2 split equals ASD. Paradoxical S2 split, what is the cause? Paradoxical S2 split. Nice. Blah has got it. You're thinking of either aortic stenosis or left bundle branch block. And then wide S2 split equals okay, kind of the opposite. You're thinking more pulmonic stenosis and right bundle branch block. Nice. Or Cathar, I'm sorry if I'm mispronouncing it, Lola, right ventricular hypertrophy also matches, right? Because that pulmonic stenosis could lead to right ventricular hypertrophy. Anything that, slows down the right heart. Good. All right, let's do another kind of algorithm here. What is, let's see, Blood depends on the conduction of the heart, right? That's basically what we're talking about, right? If the hypertrophy interferes with like the Purkinje fibers, the right bundle branch, then you can make an argument that it could also cause a wide S2 split. So I would look more at the conduction. All right, cool. No worries. Okay, let's talk about chest pain differentials. Okay, if an adult comes in with heavy dull chest pain, what's the cause? Okay, cool. Dull is on the right track. You could collectively say it's a coronary disease, acute coronary syndrome, okay, which could be probably an MI. Okay, if they say that the heavy dull chest pain is only during exercise, what would it be? Only with exercise, then you're thinking of stable angina. If they say it's even at rest, then you're thinking unstable angina. Okay, it could also be STEMI. It could also be NSTEMI. Okay, that's kind of like chest pain all the time, not related to exercise. Okay, so if it's only with exercise, it's stable angina. If it's at any point or not related to exercise or at rest, then you're thinking of these three things. Okay, unstable angina would have no negative cardiac enzymes to help separate it. STEMI would have positive cardiac enzymes. Do you know which one is the best one we like out of the cardiac enzymes? Okay, the troponin is the one we prefer. Okay, NSTEMI would have positive cardiac enzymes, but it will not have no ST elevation. It's kind of in the name. NSTEMI, non-ST elevation MI. No ST elevation on EKG, but they still have positive cardiac enzymes. Hey, hi Adogu, welcome. So NSTEMI, again, it has different EKG changes, which can be variable, but they won't have an ST elevation. And usually, most of the time, it's going to have like clean coronaries, right? You won't see any blockage on like during PCI. Okay. All right, so the point is chest pain that is heavy and dull is usually coronary or ischemic related. Okay. The point also is, guys, anything with MI or angina is never, ever, ever, ever gonna have sharp chest pain. In questions, they will never say sharp chest pain, sharp or piercing or any adjective that talks about that. It's usually heavy, dull. Okay. If they do talk about more sharp chest pain, then you're thinking of something else. Okay. If they say the adjective they like to use is ripping, tearing chest pain that radiates to the back. Okay. Or to the back, like near the scapulae. That's what. Nice. They'll talk about dissection. Okay, aortic dissection. That's going to be more of a sharper, ripping, tearing chest pain, not dull. Okay, what would I see on chest x-ray for dissection? Chest x-ray would show widened mediastinum. Well done. So widened mediastinum. For my step 2 and step 3 participants here, if this patient was stable, what's your next step in management? In a stable dissection, what's your diagnostic test? Okay. The diagnostic test for stable aortic dissection is a CTA. CT angio. Nice, Dr. Alina. Wonderful. If they're unstable dissection, nice, Dr. Michael. If they're unstable, do you do anything different? Then what's your diagnostic test for an unstable angina? Sorry, unstable dissection. You still want to do something as far as diagnostic, but yes, of course, stable patient, unstable, you definitely do want to kind of go in more aggressively. In some very severe minor cases, guys, in an unstable patient, you can consider doing a TEE, transesophageal echo, in case they ask you for a diagnostic. Nice, Dr. Miriam. Naksha, that would be more like going into treatment, right? So when they want to, beta blockers, of course, to control the high blood pressure that they probably have. But as far as diagnostic modalities, think of CTA versus TEE in stable and unstable patients. Good. What if they talked about chest pain that is position related? So it's sharp chest pain that gets better when they lean forward. Nice. All right, that's classic, usually pericarditis. All right, good. All right, so that's pericarditis sharp. If they said tender chest pain, okay, or pain on pressure, so tender, what should come to mind? Yeah, it's kind of a trick question. It's usually tender, you're thinking of more like musculoskeletal pains. So I'm looking for, costochondritis, maybe some fractures, something along those lines, just to kind of separate that. So I'm looking for more MSK stuff. And if they say chest pain, that's more like the adjective I see often is burning. How would you separate that? Yeah, right. Then I'm looking for more GI, acidity, GERD like reflux, or dyspepsia. Okay, so there I'm looking for more GERD like GERD and friends. Okay. Cool, right? So these would be some differentials of chest pains. Not all of them, but can help separate that, all right, from some. So again, if it's like STEMI, angina, coronary syndrome, it's never going to be sharp. I can't stress that enough. It really helps, right? If they say sharp, I'm not, it's not MI. It's not STEMI. It's not angina. All right. Right. GERD and friends. All right. So these are all things with chest pain differentials. Let's do another one. Let's do one more. Okay. Let's see, something else in cardio. Let's talk about, I'm trying to think of some other areas we can talk about. Pharmacology. Okay, let's do some pharmacology. What is the drug of choice to treat Wolff Parkinson White? Ooh, I'm getting some suggestions: post-MI complications, cardiomyopathies. All right, the drug of choice to treat Wolff Parkinson White is procainamide, that sodium channel blocker. Okay, that's what they're gonna ask you first, right? What is the drug of choice to treat torsades? Now, torsades de pointes is usually caused by other medications, so you've got to like supportive, stop the offending drug. But if they do want a drug to treat it or medicate the treatment for torsades, then that would be absolutely magnesium sulfate or magnesium. Okay, that's the drug of choice or the treatment of choice for torsades. What is the treatment of choice for PSVTs? What is first line and then what is second line for PSVT? Okay, Abdullah's on the right track. Okay, good. User 160, blah, right? So technically this is like, pharmacology aspect, adenosine. But before we give adenosine, this is not medication. So Abdullah's got it, right? So you want to try Valsalva maneuvers first. All right, this is where they say like the carotid massage, dunking your head in ice water, things like that. So carotid, yeah. So Valsalva first, that's not a drug, obviously. And then if that doesn't work, adenosine. Okay, so that's for PSVTs. Good. What is the treatment of stable atrial fibrillation? So atrial fibrillation, okay, what's the first line for, let's say, rate control? What do you give? Nice, right? You typically give beta blockers. Okay, if beta blockers fail, what's second line? What do you add? Nice, then you add calcium channel blockers. Good, the non-dihydro version, perfect. If that fails, what's third line? Nice, healer. Good, Richard, awesome. Third, this is where we're segueing into a little bit more rhythm control. What would you give third line if it didn't work? Okay, good. Dr. Merriam, which one? Ooh, Bino has got it. Okay, Dr. Merriam, good. Amiodarone. Ooh, running off the page there. Amiodarone is third. And if that also fails, then you're out of options for pharmacology at least, and then you want to go ablation therapy. Good. What are 2 side effects of amiodarone? This is usually in step 2, step 3 students. You probably want to detect this first. You want to run a couple of tests before prescribing amiodarone. Now, it's kind of funny, but real, is any antiarrhythmic drug can cause arrhythmia, right? So you're always worried about heart issues. So outside of heart issues, good, okay? You want to check for amiodarone, you want to check for liver enzymes, you want to check for TSH, because some of the side effects you're worried about is thyroid issues. Okay, you're worried about pulmonary fibrosis. I saw that in the chat as well. Okay, you're worried about liver. So thyroid, liver, and lungs. Yeah, interstitial lung disease, right? The pulmonary fibrosis. For more step 1 students, they will also ask you amiodarone is a P450 inhibitor, CYP450 inhibitor. It can also cause skin issues. It causes like bluish discoloration of the skin. Smurf syndrome, yeah, is what I call it, right? So blue skin. Irreversible too. So skin turns blue, discolored. What is a drug you should not give with adenosine? Contraindicated drug. Oops, that's not fitting on the page. What drug is contraindicated with giving with adenosine? There's one that step 1 loves to talk about. Okay. Top shot. You're the one, you said what I was thinking of. Okay. Yes, it is the theophylline. Okay. So theophylline is it's not going to let adenosine work. So theophylline, caffeine, they have the same mechanism. So theophylline or caffeine will not let adenosine do its MOA. Good, Nacho. What is a side effect of procainamide? Okay. What is a side effect of procainamide? Nice. It can cause drug-induced lupus. Good, Angie. Good, Blanc. Nice, bite-sized. Good. What are the drugs that decrease mortality in heart failure? Now, there are a bunch of drugs you should give in heart failure, but that doesn't mean they necessarily decrease mortality. There's a few we should know. Okay, I'm seeing it. We got beta blockers. We got ACE inhibitors / ARBs. Okay, saw those. All right, K sparing. Okay, statins. And sacubitril. Good. This is the neprilysin inhibitor. ARNI is what they'll say. Now, should heart failure patients be put on other drugs? Absolutely. You have other diuretics, you have inotropic drugs like digoxin, but they don't decrease mortality. Good. Any questions so far on that? All right. I'm gonna have to sign off soon, guys. I was planning to stay longer, but I am not feeling well tonight. I need to go rest up. But I do want to hang back if you have any questions, throw it in the chat, and then I'll try to have some more questions, like practice questions, ready for tomorrow. Thanks, Yodogu. Thanks, Richard. Thanks, Top Shot. Oh, thank you, Blah. Let me see. Am I missing any? Okay. Any questions, guys, before I sign off? Oh, thanks, acronyms. Can you please do GI questions? Yeah, sure. Let's do GI tomorrow. Lola, thanks. Thanks, blah. If patient with PSVT and he's asthmatic, what should we give? Hi, Mimi. Welcome. Yes, I do try to go live around this time every night. So it and I'm trying to keep a theme now. So today we did cardio. Tomorrow let's do some GI then. Okay. Let's see. Oh, sorry. So there's a question Abdullah asked. If you can't give adenosine, then you would give more of like a calcium channel blocker. And that's not too high yield. I don't think I've seen that, but yeah, then you would give more calcium. Thanks, acronyms. All right, guys. I'm gonna have to sign off, and I'll see you guys tomorrow. Let's do some GI tomorrow. You're welcome, Abdullah. Okay. Have a great evening or morning, wherever you guys are in the world.